Welcome to this voice annotated presentation on alcohol abuse and alcohol dependence, collectively known as alcohol use disorder. The learning objective for this module will include understanding the epidemiology of alcohol use disorder, understanding the diagnostic criteria for alcohol abuse and alcohol dependence, understanding the etiology of alcohol use disorders, understanding the medical, psychological, and social complication of alcohol use disorder, understanding basic management of alcohol use disorder, as well as understanding the prognosis of alcohol use disorders. The outline to be covered includes epidemiology, local studies compared to Western studies, the diagnostic criteria based on the DSM-4 text revised version, the causes of alcohol misuse in terms of the biopsychosocial model. We also take a look at the complication of alcohol use disorders, the non-pharmacological management, as well as the pharmacological management of alcohol use disorder. And lastly, we also take a look at the prognosis of alcohol use disorder. A local study has shown that over a duration of 12 years from 1994 to 2004, there has been an increase in binge drinking from 5.1% to 10%. According to the Singapore Mental Health Study, lifetime prevalence of alcohol abuse is 3.1% and 0.5% for alcohol dependence. However, only 1 in 5 of them have sought treatment. The ratio of male to female is 5:1. People with alcohol use disorder are also at higher risk of having major depression. Compared to numerous studies done in Western countries, the prevalence of alcohol abuse in Singapore is comparatively lower. The diagnostic criteria from DSM-4 text revised for alcohol abuse is outlined. At least one of the 4 points listed in criterion A within a 12-month period is required in order to make the diagnosis. The diagnostic criteria from DSM-4 text revised for the alcohol dependent is as outlined. 3 or more points listed in criterion A within a 12-month period is required to make the diagnosis. The causes can be categorized using the biopsychosocial model. Biological factors include family alcoholism and genetics. The genes involved are commonly involved with the physiological effects of alcohol and the metabolic pathway of alcohol. The self-medication hypothesis referred to the use of alcohol to palliate distress in someone with self-regulatory deficiencies as an attempt to re-establish homeostasis. Learning theory, as described by Perloff, could also be used to explain this behavioral pattern as a result of its association with conditioned stimuli and from actions of positive, pleasant effect on negative stress reduction behavior reinforcement. Expectancy described how abusers usually overemphasize on the positive effects and ignore the negative ones. Other psychological comorbidities and social factors are as listed also contribute to alcohol use disorder. It's important to recognize that alcohol can result in a whole spectrum of complications ranging from acute to chronic and from social to psychological and physical. The significant and the most common complication or consequences are as listed. Non-pharmacological approach to managing alcohol use disorder include psychosocial rehabilitations, which include step down to halfway houses, using motivational interviewing to shift patient motivation towards actions, and the 12-step approach by the Alcoholics Anonymous. Other interventions such as social skills training and motivational enhancement therapy might be beneficial as well. During the acute detoxification phase, the main principle is anticipation and supportive management. The most common used class of drug is benzodiazepine. Anti-epileptic is seldom used even in a planned detoxification unless the patient has had multiple history of seizure during a previous withdrawal stage. In the long-term management, the key is to improve abstinence and prevent relapse. There are 3 drugs that could be used, each with its side effect profile. Disulfiram is relatively safer to be used in patients with deranged liver function tests, however, efficacy is often limited by compliance. Acamprostat is not available in Singapore. Naltrexone may be contraindicated in patients with liver dysfunction. Bad prognostic factors include the presence of brain damage and comorbidities, previous criminal record, low IQ, poor support, and low motivation. Factors associated with high relapse rate include male gender, being young of age, with relatively poor social support, greater alcohol consumption prior to treatment, and poor compliance with drug therapy. In summary, alcohol use disorder are becoming more common and important in our clinical practice. DSM-4 text revised diagnostic criteria is commonly used for alcohol abuse and dependence. It shares many similarities with ICD-10 criteria, not presented in this presentation, but some differences are present. The etiology of alcohol use disorder is multifactorial. It's important to treat a patient with alcohol use disorder in a holistic approach to address both the physical and psychological complication. There are various pharmacological and non-pharmacological treatments to alcohol use disorder. Identify patients with bad prognosis and high relapse rate is important in planning of long-term monitoring and treatment. Key references are as outlined. Thank you.